And we've got some fantastic speakers for you this afternoon from India and from the UK who are going to talk about their expertise in the management of COVID. So we would like to just remind you that if you can keep your microphones off during the presentations, and also that there will be opportunities for questions in the chat. So please put your questions in the chat and we will answer them as quickly as we can. Unfortunately, we won't be able to answer questions that are relating to specific clinical scenarios or questions about family members. However, we will provide as much information as we can around the management of COVID specifically. There will be a short Q&A at the end of the session, so hopefully all your questions will be answered. Without further ado, I'd like to hand over to Dr. Nikhil Tandon, who's a consultant endocrinologist and head of department of endocrinology, metabolism and diabetes at the All India Institute of Medical Science. And he's going to talk about the situation in India and give us an update on the Indian guidelines for management of COVID. Dr. Nikhil Tandon, thank you very much.
Thank you, Tara, and a very good afternoon, good evening to the attendees of today's session. My remit today will be to speak to you in two areas. Number one, India's national guidelines for inpatient management of COVID-19, and then as an endocrinologist, our hyperglycemia management guidelines for people with COVID-19. Could I have the next slide, please? So without going to details of categorization, individuals with moderate COVID-19 has a differential rate of more than equal to 24, breathlessness, and an oxygen saturation between 90 to 93% in room air are advised hospitalization in a ward facility. Of course, more serious patients are then transferred to or directly admitted into the ICU. With moderate disease is actually admitted in the ward. The key aspects of his or her therapy are oxygen support, awake proning, corticosteroid therapy, and anticoagulation. The oxygen support is done with keeping a target SpO2 of 92 to 96%. That's brought down slightly to 88 to 92 if the person has chronic obstructive airway disease. The preferred device for delivery of oxygen is a non-rebreathing face mask. But clearly, if you're compelled to use a high-flow nasal cannula or a simple nasal cannula, it is recommended that a surgical mask is put on top of that to prevent aerosol generation. In terms of awake proning, it's used as a rescue method as part of the NIH protocol. In terms of the corticosteroid therapy, the preferred medication is intravenous methylprednisolone given at a dose of 0.5 to 1 milligrams per kg, or dexamethasone given as 0.1 to 0.2 milligrams per kg. Anticoagulation is done either by as a prophylactic with either unfractionated heparin or with low molecular weight heparin at a dose of 0.5 milligram per kg per day of something like enoxaparin. So that's the terms in terms of medication. I will come down to certain special medicines in a minute, but what else do we need to monitor? We advise monitoring of the work of breathing, hemodynamic stability, and the change in oxygen requirement to take a decision whether the patient's care needs to be escalated to an ICU setting. Serial chest x-rays, HRCT is not recommended on a routine basis, only if you're suspected special circumstances or if there's worsening. In terms of laboratory monitoring, CBCs, kidney and liver functions done daily, and if that's not workable, once in 2 days, CRP and D-dimer every 2 or 3 days, and interleukin-6 in a case of deterioration subject to availability. And all of this is available on the through the link which I've provided at the bottom of the slide. Could I have the next slide, please? But there are some medicines which are used either in the form of emergency use, authorization, or off-label use, very specific circumstances. Remdesivir, which has had a bit of a roller coaster ride, but at the moment it is advised under EUA to be considered, but only in patients with the following: moderate to severe disease requiring supplemental oxygen. They should have no renal or hepatic dysfunction as defined by an estimated GFR of less than 30, or liver enzymes exceeding 5 times the upper limit of normal, and the patient should be within 10 days of symptom onset. Tocilizumab is considered as an off-label therapy and can be given when all the criteria listed here are met. Severe disease, preferably within a couple of days of onset, especially those who are not improving despite corticosteroids, and significantly elevated inflammatory markers, namely CRP and IL-6. Convalescent plasma actually was used quite frequently previously, but it's clearly off-label and is again used when all the following criteria are met. Early moderate disease within 7 days of symptom onset, and availability of a high titer donor plasma. Could I have the next slide, please? And that's all I'm going to talk to you about national guidelines. Happy to answer any questions pertaining to that. But I'll now shift to diabetes management in COVID facilities. And once again, these were guidelines which were created by our department, and they have been incorporated in totality by the Government of India, and they're available as a document at the link which is provided on this slide. What really prompted us to do these guidelines were the following 2 or 3 observations. Number one, that obviously at the early part of last year, we realized that there was enough data which is indicative of the fact that people with either newly diagnosed or established diabetes had really poor outcomes. Secondly, that there was lack of attention on non-respiratory parts of management. The management teams would really focus entirely on respiratory management, and this didn't really get a look in. And the third part was that there's hardly any glycemic monitoring happening. So if you don't find the problem, you're not going to fix the problem. Could I have the next slide, please? Right. So the guidelines as they stand, and this is a very, very sort of summary, it is now incumbent on the receiving team to ask the question, do you or do you not have diabetes? Now, really, disease like diabetes, the rule of halves predominates. About 50% of people, or give or take a few, will not know they have diabetes in India, especially in the smaller towns and cities, right? So just getting a no as an answer doesn't really mean anything. And therefore, we then put a 3-step screening policy in stage. One was a point of care capillary blood glucose or random glucose done at the time of receiving the patient into the facility. The second was doing a pre and post meal blood glucose, again by a capillary test. The next meal the patient has, so the patient's admitted during the day, and if they're having a meal at night, then a pre and post dinner value. And the third screen was the next morning with a venous plasma glucose and an HbA1c to see that if the sugars were high, are we dealing with somebody who's previously undiagnosed disease or fresh disease? Now, what really ended up with this was that we ended up with 3 categories. Obviously, if all the screens were negative, it meant that the individual was normoglycemic. We must, however, remember that even somebody who's normoglycemic now can, with disease progression or introduction of corticosteroids, evolve into diabetes, right, or hyperglycemia. And therefore, we still recommended that every second or third day, some form of continued monitoring needs to be done. The other 2 situations would be stress hyperglycemia or clear disease. And then what we did was, if the random glucose, right, if the random glucose was in excess of 10 millimoles per liter or 10 to 12 millimoles per liter, we said, keep an eye on this patient. But if the random glucose exceeded 15 millimoles per liter, we said, start therapy. And I'll come to therapy in a moment. If similarly, if the pre and post meal value was more than 10 before the meal and more than 15 millimoles after the meal, we said, get going, guys, and give some therapy. So this was really the important part because we needed to initiate therapy earlier, and that therapy could be oral or could be injectable. Could I have the next slide, please? Now, the issue is what oral medication can we use, and this obviously brought about a lot of debate. And there's several problems with a lot of these oral agents. Patients are often sick, they're not eating very well, there's unpredictability in their nutrient intake. So agents like sulfonylureas have problems with potential hyperglycemia. Agents like SGLT2 inhibitors, concerns were euglycemic ketosis and dehydration. With pioglitazone, the concern was whether they would start fluid accumulation, and if there was already borderline subclinical myocardial dysfunction, could we precipitate heart failure? And therefore, really, we were left with DPP-4 inhibitors, which are reasonably safe. And in patients who do not have severe disease and who do not have hemodynamic instability or hypoxia, we still continued metformin after taking care that none of those situations were there. and that their renal status was all right. So really the number of oral agents we could give was relatively few. Next, please. What about escalating to injectable therapies? And I think what we really decided was that anybody who had moderate to severe COVID disease or moderate to severe hyperglycemia, or anybody who was contraindicated to the couple of agents which we were comfortable in using, must go on injectable therapies. And the broad thresholds we decided was if somebody had a pre-meal value of more than 10 millimoles per liter or a post-meal value of more than 15 millimoles per liter, we said, fine, you go on injectables, but you can try a basal bolus regimen of subcutaneous, so pre-meal regular or short-acting analogs and a bedtime NPH or a bedtime long-acting analog as was available. However, if we found that the values were really going high, for example, a pre-meal of 15, 16 or thereabouts, or a post-meal which was in excess of 20 or 22, we didn't even bother giving a basal bolus. We put the person on an insulin infusion. Now, clearly, the other situation which we are dealing very significantly nowadays is steroid-induced hyperglycemia, which definitely requires nuanced care. But I will not talk about that, and Doctors Wasim Hanif and Kamlesh Kunti will take care of that. As I just come to an end of my presentation, I just want to highlight one more fact, that the other area we realized we were falling short of, and that's why we've given clear recommendations, is incorporating glycemia management in the discharge summary. A lot of these patients had first-time exposure to anti-hyperglycemic agents, so it often got missed out. The details got missed out in the summary. We said if the person came on medication and was staying on the same medication, you continue with that. If they've transitioned to insulin, see if you can transition them back to oral agents. They're staying on insulin, they must have completed their education in terms of insulin technique, in terms of log maintenance, hypoglycemia, sick day guidelines, etc., 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 so that they don't encounter trouble when they go home. They should have full information about monitoring, and a follow-up appointment must be done for their post-COVID times with a diabetes specialist and or their primary care physician as required. I think I'll stop here and I'll be happy to answer questions which come onto the chat box. Thank you so much.
Thank you very much. I'd now like to introduce Dr. Sanjay Bhagani, who's a consultant in infectious diseases at the Royal Free Hospital in London, and is going to talk to us about inpatient therapeutic management for patients with COVID-19. Dr. Bhagani.
Thank you, Dr. Sood. Good evening, everybody. It's an absolute pleasure to be with you this evening. So what I'm going to cover over the next 10 to 12 minutes is hospitalized patients with COVID-19 and evidence behind the therapies that we currently use in the UK. Next slide, please, Bernard. So in order to understand therapeutics in COVID-19, we really need to try and understand a little bit about the pathophysiology of disease. And I have to say, when we entered the first wave of COVID-19 in the UK, we didn't understand any of this, but now we do. As you can see on this, the viral replication precedes the onset of illness in COVID-19, and that by the time some of your patients who develop severe illness, your viral replication is starting to come down already, and that the vast majority of people are starting to mount an antibody response. By the time people get to critical illness of COVID-19, you really are seeing people with viral levels that are reasonably low now, and that the vast majority will have an antibody response. And so what we have learned is that in that phase of the illness, it's immunomodulatory therapy that becomes more important than antiviral therapy. Next slide, please, Bernard. And so whilst at the beginning of the first wave, we were tempted to throw in every medication that might have the possibility of working, we went back to these Hippocratic oaths that we all took when we qualified as doctors, in that first we must do no harm, and that we need to try and look at the evidence supporting the therapeutics that we were using. Next slide, please, Bernard. And so this is no news to all of you. This is a hierarchy of the strength of evidence for recommendation of an intervention And as you can see on here, that it's when you get down to randomized controlled trials, systemic reviews, and meta-analysis that you're really garnering the evidence that you need in order to put an intervention into a patient safely. Next slide, please. And so what we have learned, and this is that same phenomenon that we saw in the first slide, which is that by the time the patients reach the pulmonary phase of infection and the hyperinflammation phase, it is all down to the host inflammatory response and very little down to the viral response. You can see at the bottom, there's a number of, go back one slide, please, Bernard. You can see that there's a number of antivirals that were starting to be used in the early days, and a number of immunomodulators that were also starting to be used. And what I want to do over the next few minutes is try and show you some of the evidence behind these. Thank you, Bernard. Next slide. And so there's a number of critical randomized controlled trials that have added to the evidence that we have as we speak in 2021. One of these is the UK national trial. This is the recovery trial. This is a multi-platform adaptive control trial that has the advantage of having one control for a number of different interventions. In its first iteration, you can see these are the interventions it tested against standard of care with the primary endpoint of all-cause mortality at day 28. Next slide, please. But the advantage of a platform study is that you can add and take away interventions as evidence starts together for these trials. And you can see in its later iteration, convalescent plasma was added in, as was the REGEN-COV2 monoclonal antibodies. And then they introduced the second stage randomization of tocilizumab versus no additional therapy with the same outcome, which was mortality at day 28. Next slide, please, Bernard. Trial that is forming us of the evidence from a randomized control trial was another multi-platform adaptive control trial from the WHO. This is a Solidarity trial. And again, these are the initial regimens tested against standard of care, and this time they included remdesivir, and a primary outcome was in-hospital mortality at day 28. Next slide, please, Bernard. And then the final trial that I really wanted to put up there for you was the NIH adaptive COVID-19 treatment trial platforms. So this is the so-called ACT platforms. And in its first iteration, it looked at remdesivir versus placebo. And then as the trial has moved on, if a therapy has become successful, it then becomes your standard of care against which everything else is controlled. So let's look at the results very briefly. What doesn't work in randomized control trials? Hydroxychloroquine, lopinavir-ritonavir plus injectable interferon, azithromycin, convalescent plasma, more recently hyperimmune immunoglobulin, and some neutralizing monoclonal antibodies don't work for hospitalized patients. Next slide, please. What does work is low-dose dexamethasone, and this was shown in the recovery trial. And I really wanted to highlight this for you because there's some very important data here that will help with inpatient hospital management. So these are Kaplan-Meier plots of mortality outcomes in subgroups of patients enrolled onto the recovery trial. And if you concentrate on the graph on the left-hand side, you can see that if a patient was admitted to hospital, enrolled onto recovery trial, and got dexamethasone, if they were not on oxygen at the time of enrollment, dexamethasone was in fact associated with a slightly higher risk of mortality. And so the benefit of dexamethasone is most obvious as you look on the right-hand side in those patients that required oxygen and mechanical ventilation. The ACT-1 trial showed us that remdesivir improved time to recovery as compared to placebo, but the mortality benefit was not statistically significant. Next slide, please, Bernard. And then Solidarity also then looked at remdesivir in terms of in-hospital mortality. And as you can see, both on the Kaplan-Meier plot on the left-hand side, and the forest plots on the right, that there was no benefit in terms of mortality for remdesivir in the Solidarity trial. Bernard, one tab, please. And so there is a highlight at the bottom that even in those patients who were, if you subdivided ventilated versus non-ventilated patients, there was no benefit of remdesivir in terms of mortality by day 28. Next slide, please. Next, please, Bernard. Thank you. And so the next on to tocilizumab. This is the recovery trial, second stage randomization, final results that were published just about a week or so ago. And as you can see on the left-hand side, in terms of mortality, there was mortality benefit of tocilizumab over usual care by day 28 since randomization. And then if you go down to the forest plot at the bottom, you can see that this mortality benefit was most obvious in those patients that were already on corticosteroids at the time of receipt of tocilizumab. And so suggesting that the benefit of tocilizumab is probably most obvious in those patients either pre-treated or treated simultaneously with corticosteroids. Last slide, please. And then the final data I wanted to show you, and this is just out this week, where this is a Cove Barrier of a large phase 3 trial looking at baricitinib in terms of mortality in hospitalized patients, either requiring high flow oxygen or NIV. And as you can just concentrate on the Kaplan-Meier plot at the right bottom, you can see that there is obvious mortality benefit of baricitinib in addition to corticosteroids in very sick patients, either requiring high flow oxygen or NIV. And the last slide, please. Next slide, please, Bernard. Thank you. And so, sorry, one before, please. Thank you. And so what do we do? So what have we learned from the evidence so far? What we've learned is that in severely unwell patients who are hospitalized, all those things in red that you see up there are of no effect. All those things that are in yellow are still going on in clinical trials. And all of those that are in green have shown benefit in one sense or another of reducing length of hospital stay or in terms of improving mortality. And last slide, please. And so what do we do at the Royal Free Hospital for hospitalized patients with moderate to severe COVID-19? So we ensure that all these patients get low-dose corticosteroids. It's usually dexamethasone or the equivalent doses of prednisolone or hydrocortisone, and this is for a maximum of 10 days. If the symptom onset is less than 10 days and the renal function and liver function allows, then we use remdesivir, again, for a maximum of 5 days. More importantly, recently with the evidence from the recovery trial, if their CRP is greater than 75 or they are within 48 hours of high flow nasal oxygen, non-invasive ventilation or mechanical ventilation, then they get a single dose of intravenous tocilizumab. And I won't go into anticoagulation therapies, but most importantly, we still need to gather evidence of more therapeutics in COVID-19. And so we enrolled ongoing clinical trials. And I think I will stop there and we'll be happy to take questions at the end. Thank you very much.
Thank you, Dr. Bhagani. If you have any questions, please do put them in the chat box on the screen and we will try and answer them as the questions come up. So we're very happy to take questions in the live chat. I'm now going to hand over to Professor Wasim Hanif, who's a professor of diabetes at University Hospital Birmingham. And he is going to talk to us about the inpatient management of diabetes in COVID. And he will be followed by Professor Kamlesh Kunti, who is going to talk about the primary care management of diabetes in COVID. And he is a professor of primary care, diabetes and vascular medicine. So Professor Hanif, over to you.
Thank you. Thank you very much, Tara. And good afternoon, good evening, everyone in India. I think Professor Tandon has covered some of the areas today. So when it comes to diabetes and COVID, one of the things that became quite apparent within a few weeks, and this was shown in one of the largest studies from the UK, is that the mortality for patients with diabetes is increased. So it's increased nearly twofold in patients with type 2 diabetes and 3.5-fold in people with type 1 diabetes. We also now know from the evidence that the baseline HbA1c, or the glycemic control, has an impact in these patients. And also what became quite apparent in our settings in Birmingham, which has got a large Asian population, that there was a lot of underlying diabetes in the population. This was either undiagnosed diabetes or this was pre-diabetes, and and both with COVID infection as well as using high-dose steroids precipitated diabetes. So the glycemic or the metabolic management of these patients became challenging, both in terms of identifying diabetes and then treating appropriately. Also, some of the medications would have had an effect, both in terms of the underlying complications the patients were developing. So as a part of these guidelines were developed at University Hospital Birmingham, along with incorporating what's been done by the ABCD and other societies in the UK, trying to accumulate the evidence and trying to have a safe practice. So one of the first things that we started doing was that the key advice on admission is that all patients who come to the hospital should have their capillary blood glucose checked, because this would help to identify the ones with underlying diabetes. We also recommended that all patients who were known to have diabetes, be it type 1 or type 2, should have their ketones checked. If the blood ketones or capillary ketones are available, that's well and good. If not, urine ketones need to be checked. In terms of all patients who are admitted to the hospitals, SGLT2 inhibitor therapy, be it canagliflozin, dapagliflozin, empagliflozin, ertugliflozin, should be stopped, especially if the patient has got moderate to severe COVID. Metformin was also considered to be something that could be continued, but if the patient was dehydrated, serum creatinine levels were rising, lactate levels were rising, or if the eGFR was less than 30, then metformin had to be stopped. All patients who were on insulin, be it either type 1 or type 2, their insulin had to be continued, especially the background insulin, or what we call the basal insulin, things like Lantus, Levemir, Tresiba, Humulin I, and Extra. The other important point was to identify the patients with DKA and HHS. It was very important because this was noted to be much more higher in patients with COVID. We were also seeing DKA in patients who previously had type 2 diabetes. But at the same time, it was also important to look at feet and other things. Just to give you a scale of the problems, in our published data from our trust, a third of patients with COVID admitted to the hospital had diabetes. This was in the white population. In the South Asian population, it was nearly 50%. So underlying diabetes was a big issue. Next slide, Bernard. So one of the things, and Professor Tandon did mention before, one of the challenges is that how we manage diabetes. So there are two pieces of approaches that we would take. The first piece of approach is when it comes to most of the patients who are being managed on the wards, receiving oxygen, it is important to kind of let the patients self-manage their own diabetes, because we know during the pandemic, when the nursing staff is stretched, when the hospital care staff is working, most of these patients know how to check their blood glucose, inject insulin. So it is important to encourage them to manage their diabetes. The target blood glucose should be somewhere between 110 to 270. because at the same time you're trying to manage diabetes, it's also important to avoid hypoglycemia. VRI or insulin sliding scales can be used, but because of the pressures on the staff, sometimes it is not possible to check the blood glucose regularly and change the insulin sliding scale. So if insulin sliding scales are being used, it is important to continue using basal insulin. Now, when it comes to the ITU or critical care management, now this is proven to be quite challenging for a few reasons. Most of these patients would end up on a sliding scale insulin, but the amount of insulin the patients with COVID require is very high. So the standard sliding scales don't work. You may have to go up to as much as 20 units per hour. So you need to be bold, and the thing that guides you is the blood glucose level. So sometimes the amount of insulin levels need to be high. The other thing we need to be aware of, and this is something that has been seen a lot, especially in the COVID infection setting, is euglycemic decay. This is what you get with SGLT2 inhibitor therapy mostly, but sometimes you can get without. And in this, the blood glucose levels will be normal, but the patients will have high levels of ketones in the blood and urine, and they will be acidotic. And these patients have to be managed as per the DKA protocols. The other important element of diabetes management is the therapies that need to be stopped, especially if the patient is unwell with moderate to severe COVID. So the acronym that is being used and quite popular is something called as SAD-MAN. And this includes SGLT2 inhibitors, ACE inhibitors, diuretics, metformin, angiotensin receptor blockers, and SEDs. Next slide, please. Now, one of the other challenges that has happened, as Nikhil mentioned earlier on, was the use of dexamethasone. As we know from the recovery trial, dexamethasone in appropriate patients can reduce death by nearly 1/3, and it's now become a standard treatment for COVID. Now, one of the challenges with using dexamethasone, both in patients with diabetes, underlying undiagnosed diabetes, and even in pre-diabetes, is it can precipitate either stress hyperglycemia or get the blood glucose levels very high. There have been various steroid protocols developed. I'm going to just mention the two. One of it is generally a ward-based protocol. So in this protocol, you tend to use sulfonylureas as the first line of therapy, which is quite different from standard therapies. You start with gliclazide at a dose of 40 milligrams at 8 a.m. and another 40 milligrams at 12 p.m. So you don't give it in the evening, but give it at 12. This is to mimic the circadian response of steroids and zone. The dose can be increased to 80 milligrams if still the blood glucose levels are increased. And it is important to check the blood glucose levels at around 4 p.m. because that is when you notice the rise in the blood glucose levels, because the morning blood glucose levels can be low. And then you can add insulin. We generally recommend medium-acting insulins like Humulin I, Insultard, or Levemir to be given at 8 a.m. and the dose to be titrated. If the patient is in an ITU setting, of course, they will be managed by sliding scales. Next slide, please. So when it comes to the DK management, I'm not going to go through this. We will probably going to we will share these slides. The important thing to remember is the few things. Diagnosed DK in COVID patients more common. Consider ITU referral if the patient is young and has got severe DK. You need to restore circulatory volume, continue fluid replacement, and start insulin therapy. Next one. And the most important thing is to monitor the patients because the monitoring and checking ketones and glucose is very important. And finally, when there is a DK resolution, you need to put them back on their normal insulin regime. At this point, I'm going to hand over to Kamlesh to talk about glycemic management in the community settings with COVID.
Thanks very much, Wasim. So I haven't got slides. I'm just going to talk you through a few issues regarding management in the community setting. So Wasim's already mentioned diabetes is a major risk factor for admission for hospital and for severe COVID, twofold increased risk with type 2, threefold increased risk with type 1 diabetes. And there are direct and indirect impact of diabetes. In terms of the direct impact of people with diabetes, it's really important that people who are in the community, they have their risk factors managed, and particularly HbA1c. This has been shown that if people are admitted with a high HbA1c with COVID, they have worse outcomes, particularly for type 2 diabetes. An HbA1c greater than 7.5% increases the risk of worse outcomes, particular mortality, by about 30%, and the risk increases linearly. For type 1 diabetes, surprisingly, once we're adjusted for everything, your risk is increased after an HbA1c greater than 10%. But whatever type of diabetes, it's important that you continue managing people with type 1 and type 2 diabetes appropriately so that their HbA1c is low, just in case if they do catch COVID, the risk of mortality will be lower. Secondly, it's obviously, goes without saying, it's important to get all of these people vaccinated as a priority because of the high prevalence of people who are admitted to hospital with COVID-19 and the worst outcomes that they get. The other question being asked is what therapies should we continue using? Because there was a fear when COVID came through, and there still is in the community setting, that we shouldn't be using certain therapies, such as SGLT2 inhibitors. As you saw, Wasim already presented that SGLT2 inhibitors are recommended to be stopped in hospital, but I'll come to that a little bit later on in terms of the hospital setting. In the community setting, all therapies are safe to use. So we've just published, I think 3 weeks ago, a large study, 2.8 million people, showing all the therapies are safe. So whatever therapies patients are on, please do not stop them. And whatever therapies that you would be starting these patients on, do start them. There were increased association with insulin in terms of mortality. However, it's not an issue with insulin, but these people are more advanced. They have a lot more risk factors. That's the main reason that you have a higher association on people with insulin. But it's really, really important that these patients are managed with insulin as appropriately as possible. The one thing I think everyone in the community should be doing is managing all chronic diseases appropriately. We will see more people die of indirect impact of COVID-19 than direct impact of COVID. Yes, we are seeing huge numbers of patients being admitted to hospital with COVID, but those patients who are at home, they've had no management, many haven't had management, and we've had the same in the UK as well. We're managing these people remotely. They haven't had their regular checkups in terms of their risk factors. They haven't had their blood tests done. What's been shown in previous pandemics, such as Hurricane Katrina, for example, is that people with diabetes and other, in fact, chronic diseases, such as cardiovascular disease, they have short-term worsening of risk factors. And it's not just because of the pandemic and we're not seeing them, but we know that the lifestyle has changed. People are getting more obese during COVID because of lockdown. People have much heightened levels of depression, and this is associated with poor adherence. And all of this leads to worse risk factors. And so in the short term, we will see worsening of risk factors. But when we learn from other natural disasters that have happened, as I mentioned, such as Hurricane Katrina, within the medium term, we're talking within 2 years, you get worse outcomes, both microvascular and macrovascular and mortality outcomes. So the number of people who may get worse outcomes who haven't directly been affected with COVID could be quite significant. So it's really important that we manage these people. There's been enough data shown by many people that just a 1 year delay in getting HbA1c down to normality, just 1 year delay, and that's what we've had in COVID, is associated with worse outcomes within 5 years in terms of myocardial infarction, hospitalization for heart failure, strokes, microvascular complications, and mortality as well. Fourthly, patients who are discharged from COVID. These people are hugely insulin resistant. They have worse risk factor control when they come out. They're not that physically active. And so it's important to monitor these people's risk factor and control it appropriately as they come out. We have seen from our data and other data that once patients come out from hospital, about 10% will die within 140 days. And about 30% will be readmitted. And many of these readmissions are due to cardiometabolic risk factor, cardiovascular disease, CKD, and new onset diabetes as well. So when patients come out, please do monitor their risk factors. Then fifthly, coming to new onset diabetes, and you've heard about this in terms of a new phenomenon that people who've been admitted with COVID may get new onset diabetes. This is not a new phenomenon. We've seen this in other acute illnesses. We've seen this in other acute infections, viral infections as well. Now, whether this new onset diabetes is increased because of SARS-CoV-2, we're not sure. There have been patients who have a higher prevalence of new onset diabetes of those who are hospitalized. Recent systematic review showed it's about 14%. But there may be people in the community who've had COVID, they may get new onset diabetes. So these, again, people who've had COVID, they should be assessed for new onset diabetes within 2 to 3 months. So that's something that one should do as a normal routine measure of risk factor assessment and control. And finally, vaccinations. We are hearing, these are case reports, that people with diabetes who get vaccinated, they get increased blood glucose levels within the first few days of being vaccinated. I haven't seen any data that's been published on this at all, but a number of case reports we're hearing about. And this may be because of the vaccine inducing immune-mediated response. So I'll leave it there. Those are the 6 points I wanted to cover in terms of community. But we can come to a bit later on about SGLT2 inhibitors, the DARE trial, which I know Nikhil was initially involved with. Hyperglycemia, I don't know if Nikhil and Wasim have covered this in hospital patients. Hyperglycemia in hospitalized patients is associated with worse outcomes in people with and without diabetes. And in fact, admission hyperglycemia in people without diabetes who are hospitalized is even worse than people with diabetes. And I think this is because Wasim mentioned that you have a sliding scale management of people who are admitted with diabetes. So we alert to hyperglycemia, we put them onto insulin, but people who do not have hyperglycemia, who do not have diabetes, we're not likely to put them onto insulin very quickly. And all the data so far has shown that admission hypoglycemia is worse in people without diabetes than diabetes. So that's something to think about as well. Thank you very much.
Thank you both. We're now going to move on to Dr. Pratima Chowdhury, who's a consultant haematologist at the Royal Free in London, and she's going to talk about anticoagulation therapies in patients with COVID-19. Dr. Chowdhury.
Thanks a lot, Tara. Thanks very much. Good evening, everyone. It's a great pleasure to be part of this webinar, and over the next few minutes, I'm going to try and give an overview about anticoagulation in the context of COVID-19. Next slide, please. I think very early in the pandemic, we saw this association between D-dimers and COVID-19. And I think as the pandemic progressed, what we realized is that the elevated D-dimers was associated with both an excess risk of thrombosis, but also an excess amount of mortality. I mean, there have been n number of systematic reviews published, but I think the most important take-home message from the systematic reviews is the variation in the VTE that we see across different cohorts, suggesting that how you diagnose the patients is going to have a huge impact on how many patients you find with venous thrombosis. And if you look in terms of D-dimers as a prognostic marker, what we have again find, the literature says that if you have a 4 to 8-fold increase in D-dimers above the upper limit of normal, then the mortality may be almost be twice in any kind of age group, or if you kind of stratify by gender. So within this context, therefore, I think there's been a lot of interest in saying, what can we do to manipulate the coagulation that can improve the patient outcomes? Next slide, please. So I think the first thing that we kind of need to think about is, why do we need to investigate patients for a pulmonary embolism or venous thrombosis? We know that the patients, once you diagnose, they require anything between 3 to 6 months of treatment. But the symptoms of PE are quite indistinguishable from that of COVID-19. So I think typically, what we have learned over the 2 surges is, particularly in ventilated patients, if the patient is not improving after you've prone them for 48 hours, if there's a sudden worsening of the PF ratio, if there's a sharp elevation of D-dimer levels, where essentially the D-dimer levels have doubled or more than 5 to 10,000 or even 80,000, then that is the time you think about a CTPA. What about the ward patients? Similarly, in the ward patients as well, if there is a D-dimer that is more than 5,000, an absolute value, or if there's a sudden deterioration in the saturation in a patient you think is improving, and then you do a dimer and there is quite a marked increase or a sudden doubling, then again, these patients, you kind of do a CTP, and if it is positive, you initiate them on anticoagulation. Next slide, please. So I think, taking a step back, why are we interested in terms of anticoagulation? Well, what is it that we want to try and achieve in this group of patients? The first thing we have said is in terms of decreasing the amount of symptomatic venous and arterial thrombosis, but there is also this bigger desire to decrease the need for oxygen support and ventilation. But I think fundamentally the issue that the reason there are so many studies on clinicaltrials.gov, there's almost about 150 studies, is we want to see if anticoagulants are going to decrease mortality. Next slide, please. And in fact, this has been done by 3 groups of investigators. They combined their study, they combined all of their studies to kind of a similar study design. And this was the multi-platform study that came from the US and also the Canadian and the UK and the European groups. And what they essentially showed was that therapeutic anticoagulation in severe COVID-19 does not improve survival. I think as expected, we saw fewer thrombotic events with therapeutic anticoagulation, but it did not result in a decreased amount of mortality. And if you do it even as a composite endpoint, there was no advantage. I think the other thing is there was no difference in terms of major bleeding. But I think there is always the kind of value that if you put in anticoagulation in a patient who is ventilated, then it kind of comes with its complications of trying to manage the anticoagulation. Next slide, please. But what you essentially see is, in contrast, if you look at the moderate COVID-19 patients, again, it's the same group of investigators. These results came out in about January time. And what they showed is that in terms of the primary outcome, it was superior. Therapeutic anticoagulation was superior to standard of care in patients with moderate COVID. And this was not related to the D-dimer level. So although the stratification was done on the baseline D-dimer, it did not have any impact in terms of the outcomes. Next slide, please. So I think if we kind of want to summarize, how are we going to implement an anticoagulation strategy for our COVID-19 patients? I think mostly you would probably give a prophylactic dose to any inpatient who has got a bleeding risk. But otherwise, if there is a patient who has been admitted for supplemental oxygen or is admitted because you want to give him steroids, I think these are patients who now would be better treated with a therapeutic anticoagulation. We can either use a heparin or a direct oral anticoagulant. But if this patient then progresses requiring more amount of oxygen, because there has been no real survival benefit of therapeutic anticoagulation, the recommendation now is that we drop the dose of anticoagulation to what we call as an intermediate dose, where essentially you double the dose of the prophylactic dose. Next slide, please. So I think in summary, what we can say is that D-dimers are correlating with the disease severity and the mortality. We don't understand completely the fact that why the anticoagulation isn't working. What we do know is that the hypercoagulability is multifactorial, and there is also some amount of inflammation of the endothelium. And the burden of venous thrombosis in this group of patients has got 2 sources. The first is the development of in situ pulmonary artery thrombosis, but you also have the embolization of thrombi from deep vein. I think the important thing for us to remember is that therapeutic anticoagulation is very beneficial in patients requiring supplemental oxygen, but has no real survival benefit when initiated in patients requiring high oxygen support. Thank you for your attention. I'll hand over back to Tara.
Thank you, Pratima. And our final speaker this evening is Professor Ramani Munasinghe, who's the National Clinical Director for Critical and Perioperative Care at NHS England and Improvement. And she's going to give her experience on managing patients on the intensive care unit with COVID-19. Thank you very much.
Thank you, Tara. Good evening, colleagues. It's a real privilege to be with you today. So my role over the last 15 months in England has been mostly around trying to help coordinate and manage the national response in intensive care or critical care for the NHS in England. I've done relatively little clinical work at the bedside, although I have done some. But what my role has given me is a real bird's eye view of the different challenges faced by different colleagues in different hospitals, in different setups, and therefore I hope will give you a really good overview of the potential challenges that you may face over the next weeks and months relating to the treatment of intensive care patients. Next slide, please. So the summary slide is here at the beginning. We have really good guidelines for how to treat patients with COVID-19, including in the intensive care unit. So these are some links to some guidelines that you'll be able to access on the internet. The first link is professional body guidance developed in the United Kingdom for use in intensive care. And I really would, if you are treating patients in ICU, I really would recommend reading these. The second is NICE guidance, which gives a bigger overview of the management of hospitalised patients with COVID, and obviously the WHO website has got lots of resources. I will go through some of the specifics of treatments for patients in the intensive care unit, but our experience collectively in the United Kingdom is that you can learn a lot by reading, but treating patients gives you an experience that it's impossible for me to convey to you. You have to just get that experience. But aside from that, the biggest challenges that you're going to face are likely to be related to surge, and I'm sure in many places you're already experiencing that, and how to deal with demand exceeding supply of various things. And the key things really that I can think of are the workforce, the people. Oxygen in the United Kingdom, we're hearing a lot about this. I don't know how much of a problem it is in every hospital, but certainly we faced oxygen shortages for different reasons, perhaps to you guys, during our big surges, and I'll talk a bit about that in a minute. Equipment, both hardware and the consumable items, so like masks and tubes and all those things, and medicines, and not just the medicines that work like IL-6 inhibitors and so on to treat COVID itself, but the simple stuff like sedatives, drugs to intubate patients and so on. At times we had to manage with shortages of the stuff that we would use as our first line, and to develop workarounds, and those are the things that you may face over time come as well. So the greatest pinch point of those four things will probably determine the compromises which might be required in the treatment of your patients if you are seeing greater numbers of patients than your units are designed to normally treat. Next slide, please. So I'm going to go straight in with the choice of ventilatory support for patients who require anything other than just simple face mask oxygen. And there really is equipoise over the right thing to do here. If the patient has an immediate indication for intubation, like their GCS is low, for example, then obviously intubation is the right thing for them. But in most cases, you have patients who are hypoxemic and breathless, but don't necessarily look as if they need to be intubated immediately. And then there is real equipoise over what to do, whether a trial of CPAP or high flow nasal oxygen may have benefit, or whether you should go straight towards intubation. Now, in the UK, our clinical experience developed over the last 15 months is very divided. There are units that are intubate early units, and there are units that will try CPAP on pretty much every patient before intubating them. And everyone has had good experiences. There really is clinical equipoise on this. And there was a trial, the Recovery RS trial, which was trying to evaluate which of these interventions worked, but it stopped recruiting, probably because it stopped recruiting early. It hasn't reached its target sample size. we lost equipoise because, as I say, our system was very divided as to, this hospital is an intubating hospital and this hospital is an early CPAP hospital. Next slide, please. So in some respects, that's good because it kind of gives you a free choice of what to do dependent on what your local setting and circumstances are and what as I say, your pinch point is. So I guess it's obvious that CPAP in general will require a lower level of nursing and monitoring, which is obviously a good thing if your workforce's numbers are an issue. And it's generally well tolerated apart from the usual issues that you get with face mask CPAP, so mask fit, the potential for pressure ulcers, particularly on the bridge of the nose. But the challenge is that almost all CPAP devices are very, very oxygen hungry, particularly wall CPAP devices. And this becomes a massive problem if you have mask leaks as well, because the devices automatically compensate by giving more oxygen if there is a leak in the circuit. So this is clearly a massive problem if oxygen is a limited resource, and CPAP off cylinders, unless they are those gigantic cylinders, really doesn't seem like a very sensible idea at all. And related to that, some CPAP devices dispense large volumes of oxygen into the environment, which if you're in a poorly ventilated environment or an enclosed space, a pop-up intensive care unit can be a potential fire risk. High flow nasal oxygen, similarly, it's very well tolerated and low level of nursing and monitoring is required. But again, it's hugely oxygen hungry. That stands to reason, 30, 40 litres of oxygen or more. And similarly, quite a lot of CPAP devices require 30 litres of oxygen or more. Home CPAP machines, which are used for patients with obstructive sleep apnea, which can have oxygen added to them, are much less oxygen hungry. And we have some tables which show the oxygen utilization of different CPAP devices at different levels of CPAP and different FiO2s, which may be of use to you guys, and I'm very happy to share. And then when it comes to mechanical ventilation or IPPV, obviously it's invasive and it requires sedation, which means that you then have the problem of finding the medicines and feeding the patients. And it requires, without a doubt, a higher level of nursing and monitoring support. Fully sedated patients may be easier to manage than weaning patients, and that is again something to consider. Next slide, please. In our first surge, when we didn't have enough formal ventilators to manage, formal intensive care ventilators to manage every patient that came in, we used anaesthetic machines with circle breathing systems to ventilate patients at times. This can definitely be done. It's not what one would choose to do, but it's definitely better than not having a ventilator. Now, anyone in the room who uses an anaesthetic machine normally will know that they're usually used with circle systems with soda lime and therefore low oxygen and air. If you are ventilating a critically ill patient using an anaesthetic machine, higher flows than usual are very likely to be required to avoid build-up of condensation within a circle system. And then there are some issues that are specific to using anaesthetic machines, such as, for example, if you lose inline suctioning, which is what we would normally do, and certainly is the safest thing to do with COVID patients because it reduces the risk of aerosolization with suctioning, that can trigger anaesthetic ventilators to stop. So that's obviously something to be aware of. You need to be careful about where you put your carbon dioxide sampling, and you need to think about where you put, how you use heat and moisture exchange filters, because these can become rapidly saturated with water and cause an occlusion in the circuit, which can shut off ventilation at short notice. So all of these are problems that can be overcome, but the nursing staff that are looking after patients on these machines do need to be aware of these limitations, particularly if they're not used to working with anaesthetic machines in general. And in fact, even if they are, because ventilating ITU patients for hours or days is not what they were originally built for, but they can be used if you need to. Next please. So if you've given a patient CPAP, one of the really big challenges, I think, is knowing when to give up and intubate the patient if they're not improving. And there are signs of CPAP failure which are kind of, in some respects, obvious. The patient develops an increased work of breathing, their oxygenation falls, and so on and so forth. And if this happens, in some respects, your decision is straightforward. However, what we have found is that some patients can look pretty good on CPAP for days and days and days and days. And then eventually, when they deteriorate, their lungs are really, really bad. And when they're intubated, they are incredibly difficult to manage. And for that reason, despite what I've said in this second paragraph here, which is that there is no evidence that a particular duration of non-invasive respiratory support, or CPAP, is detrimental in treating a COVID patient. There were some units in our country that adopted guidance which said that after 5 days, they would have a sort of go, no go decision about intubating the patient, because they didn't want to run the risk of leaving a patient on CPAP for days and days and days and days, only for them to do badly later. It's a very, very difficult challenge, because undoubtedly there are patients that have had CPAP for more than 5 days who avoided formal mechanical ventilation, got off oxygen and went home. So it is, there is no easy answer to this, but I guess continually monitoring the patient, doing x-rays for signs of barotrauma like pneumomediastinum and so on, looking for signs of self-induced lung injury is perhaps one way of trying to solve this problem. And there are some scoring systems such as this one here, which is referenced, which may also be of value in trying to predict failure of non-invasive respiratory support. Next slide, please. So the principles of ventilating patients, it's your usual best practice in ventilation. So limited tidal volumes, if possible, avoidance of high airway pressures, and using higher PEEPs, but probably not more than 10 centimetres of water, because that's unlikely to be of value and may cause further trauma. Permissive hypercapnia will be fine in order to preserve these volumes and pressures. And later in the disease, the patients do develop classic stiff lungs, so ventilating them at lower airway pressures and reasonable tidal volumes can be a real challenge. And avoidance of hyperoxia. So 92 to 96% is fine if the oxygen supply is no problem, but 90 to 93 is fine as well if oxygen supply is a problem, and particularly in the intensive care environment when a patient has some level of monitoring. In patients with chronic respiratory disease, going lower than that is likely to also be okay. All of this, of course, depends on the safety net around the patient in terms of monitoring and nursing support. And I'll come back to that sort of thing in a moment. Next slide, please. Thank you. So proning is something which is a free intervention, isn't it? You place the patient prone, and in some patients you see a really quite dramatic improvement in VQ mismatch and oxygenation. Unusually, we have found that awake proning can have value as well. So awake proning in patients on CPAP or high flow nasal oxygen can be of value. And certainly in patients who are intubated, proning has been usually tried to see if patients respond with an improvement in oxygenation. And if you find that the patient responds to proning, the idea is that you use it for maybe 16 to 18 hours a day. It's possible that you might use it for longer than that, and then flip them back over for 8 hours and then put them back onto their front for 16 to 18 hours. And patients may continue to show benefit for this approach for a week or even more. There are risks associated with proning, and they're predominantly related to the risks of pressure ulcers and of, I've lost my slides from the screen. I don't know if anybody else can see them. So the risk of pressure ulcers, the risk of damage to the eyes, the patient's positioning with regard to their shoulders can risk them getting brachial plexus injuries. And we've seen quite a few of those after patients have recovered and left intensive care. So these are all things to watch out for, but proning can be a very, very effective rescue therapy. I can't see my slides anymore, so could somebody put them back up, please? Thank you. And the next slide, please. Thank you. And the other challenge with proning, of course, is displacement of the tracheal tube, particularly when you're moving the patient around. Next slide, please. So thromboprophylaxis, this has been covered already by colleagues. I mean, if you look at the guidance across the whole sort of pathway of care for a patient that's hospitalised, certainly at the beginning I thought this could be potentially confusing, but in fact it's a lower oxygen therapy only should receive therapy for anticoagulation, and higher acuity patients, so those in intensive care receiving high flow nasal oxygen, CPAP or ventilated, you would reduce that to an intermediate dose, which is a twice normal prophylactic dose. You'd start quickly as possible after hospital admission, and you continuously reassess the risks and benefits of thromboprophylaxis against the risks of bleeding. I'm going to come on to talk about fluid management and renal replacement therapy, but certainly increasing the dose from an intermediate dose up to a therapeutic dose was advocated in some places where we had lots and lots of problems with hemofilters clotting. But there are obviously other solutions to that, such as, for example, heparinizing the circuits, which may be preferable. Next slide, please. Thank you. So cardiovascular, probably the biggest risk is right-sided cardiac dysfunction due to pulmonary hypertension and hypoxemia and pulmonary embolism and thrombosis. Of course, these patients can get acute coronary syndromes as well, and the diagnosis of this can be difficult because lots of patients get raised cardiac troponins as well. So echocardiography, if it's available to you at the bedside, can be useful in helping to differentiate between different coronary syndromes. Patients commonly get arrhythmias as well, probably largely related to the disruption in their oxygen delivery. And these should be managed as you would in any other intensive care patient. Next slide, please. Next slide, please. Thank you. Thank you. So fluid management. Oh, and back one, please. Thank you. So we in the UK probably got this a bit wrong when we had our first wave this time last year. The temptation with patients where the primary pathology is lung injury is to go really, really super dry. But what we found is that renal failure was very common in ventilated patients, and it put patients into a very, very poor prognostic category. The other thing that we found is that renal replacement therapy started to become a constrained resource. So the filters and to a lesser extent the machines, because we had so many patients who were requiring renal replacement therapy. So our RRT rates in intensive care went up as high as 35 or 40% of COVID patients compared to 20% or thereabouts of normal critical care patients. But that got better with the second wave because we learned some lessons from our first wave experience. So the top tips would be don't go super dry. And I think particularly in India and South Asia at the moment, because it's so hot, as you would normally do, really think hard about insensible losses when considering your fluid balance. And also remember, these patients will probably, sadly, have high airway pressures and PEEP, and this can compromise renal perfusion pressure and therefore put the kidneys at greater risk. Next slide, please. If you do get to the stage that a patient requires renal replacement therapy, then if you're using conventional hemofiltration, we found that we had to be careful about our resources. So intermittent filtration could be fine in lots of patients. And if you do have a need to preserve sets, then use a set on a patient for the maximum time that possible, and then take the patient off and the machine onto a different patient. Filter clot was a problem, and so high dose thromboprophylaxis or heparin via the circuits or saturated circuits would be helpful there. If your hospital has renal services, then dialysis can be considered if you've got a water supply that's available in the intensive care unit or can be plumbed in, and either using slow, low efficiency dialysis or SLED or intermittent hemodialysis. And a handful of UK centres ended up using peritoneal dialysis for patients on critical care, which is tricky in every respect, particularly if the patients are being proned, but it is possible in extremis. Next slide, please. So the treatments have been covered by other colleagues, but just to reiterate, dexamethasone 6 milligrams daily for 10 days is the absolute mainstay of the treatment of the hospitalised COVID patient. And I think, so other steroids can be used. If dexamethasone is in short supply, you can substitute that for equivalent doses. So it'd be 40 milligrams of prednisolone and equivalent doses of methylpred or hydrocortisone. Dexamethasone is, we ran into some challenges with women who were pregnant, who had COVID, and people being reluctant to give them dexamethasone because There is some evidence that you shouldn't do that in early pregnancy because of the risks to the fetus. But the obstetricians in our country are very, very, very clear that if a woman who is pregnant comes in with COVID, she must get her low-dose steroids, her equivalent dose steroids. And if you can avoid dexamethasone and give prednisone or hydrocortisone, then that's what you should do. But she should get the steroids. As far as remdesivir is concerned, if the patient has not received remdesivir up to the point that they are in intensive care or requiring CPAP, high-flow nasal oxygen or ventilation, don't start it then. If the patient's already on it, then you can continue for the 5-day course and then stop. And if you're using IL-6 inhibitors like tocilizumab, a single dose should suffice. As far as I'm aware, nothing else is evidence-based. And I really would reiterate to you, don't feel bad if the fancy drugs aren't available, because the biggest impact on the outcomes for your patient is going to be the general infrastructure and organisation of your workforce and your unit. And of course, given the levels of patients that you may be faced with treating, much of this will be out of your control. So yeah, look after yourselves. Next slide, please. So these are the things I would sort of, as I come towards the end of this presentation, advise that as intensive care clinicians, you really need to think about. There really is equipoise on the ventilatory support. So you must do what best fits the infrastructure that you've got. So thinking about the staffing, thinking about the oxygen demand, thinking about what the predicted numbers of patients coming into the unit are going to be, and also recognizing the fact that the numbers of patients in your unit will stay static for much longer than the numbers of patients on normal wards in your hospitals, because ICU patients stay there for much, much longer, or can stay there for much longer than a patient who comes to the ward, has some oxygen and dex and goes home, much longer length of stay. So we had a sort of rule of thumb thinking about our ICU numbers, that the half-life of an intensive care unit workload was about a month. So if you reach your peak surge, then maybe a month later, your patient numbers will have dropped by 50%. And so you in intensive care will feel the impact of surge for much, much longer than other parts of the healthcare system. Because once eventually, hopefully, vaccination or whatever public health measures are taken to try and reduce the numbers of patients coming in, once they take hold, it will take still some time for that to impact on intensive care numbers. So thinking about all of that when planning how you look after patients, I think is worthwhile. And then doing the simple things as well as you can. These are the things that often go out of the window, particularly with stretched staffing. So we have this system called FastHug. I don't know if you do in India or in South Asia, but the acronym is feeding, analgesia, sedation, thromboprophylaxis, hydration, ulcer prophylaxis, and glycemic control. So this is the good housekeeping stuff. It's also that's really, really easy to forget. And so just having this, and hydration and head up of the bed is the other H as well. And so just having someone that can go around, they don't have to be a doctor or a nurse, but someone that can go around checking that the patient has got feed or plan for feed is optimally, that they've got a prescription that seems to work for analgesia and sedation and thromboprophylaxis and all those things. That those are things that can potentially help. Next slide, please. And using your team as effectively as you can is the other thing. So we had to bring in huge numbers of additional staff to work in intensive care because we grew from our baseline of about 3,500 critical care beds up to 6,500. And so we had to bring lots and lots of additional people who are not used to working in the ICU into our intensive care units to help us. And so the way that we tried to use those guests most effectively included setting up teams to do repeat tasks. So proning teams, that's all they did. And they would have an anaesthetist and a bunch of other people who would just go from bed to bed and prone and deprone the patients. And surgeons are great for that type of thing. If they're not doing as much operating because of the surge conditions, they're used to positioning patients in theatre. They can be really, really useful for this. Line teams, so asking radiology and cardiology colleagues who are experts at putting lines in to assist with that type of thing. Intubation teams, so having a team that is there to intubate and do nothing else that is outside the core critical care team. Housekeeping teams, and communications teams very importantly with families, which can on intensive care staff as long as they're suitably supported. Next slide, please. So in my view, the key to good critical care is, next slide, the staff. And, you know, we really are all in this together. And it is hard, but flattened hierarchies can help. So everyone's got to feel empowered to be able to speak up. And in this setting, with many, many more patients than you might be used to treating in your unit, patient harm is very likely to occur due to omissions and human factors and accidental mistakes. So that flat hierarchy, that means that the most junior member of the team is able to speak to the professor and explain why they're worried about something is really important. Looking after your surge staff, so your support staff that are brought in, there are resources available to help train them in the basics of intensive care. And again, trying to allocate them in a way which maximises the existing experience they have is really important. And my final comment really is about looking after each other. We've found that psychological harm is common as a result of dealing with this level of critical illness admissions and just crisis, and is most likely to occur in the core intensive care staff, particularly senior staff, particularly nursing staff. And this is going to be a long haul rather than a short sprint. So taking time and spending time with your loved ones and taking time to eat and sleep and rest is really important. Thank you for listening.
Thanks very much indeed.
Thank you so much, Romani. I'm going to now go to Alison for questions, please.
Thanks very much, Tara. First, we want to apologise that we've overrun. It's because we've had so much information. So we hope, we're sorry about running over, but we thought what we would do is just pick up two of the questions that have been asked most frequently. So perhaps we could have stopped sharing slides and we could just see the panel so I can work out who might be able to answer those questions. And I also wanted to highlight, I put it in the chat, that NICE have produced some up-to-date guidelines. So if you have a look at those, they're a live set of guidelines and they will be updated with ongoing evidence. So please have a look at the link which is in the chat. As I said, I'm afraid we're not going to probably have a huge number of questions, but one that's come through which I'd like to ask for Pratima is actually asking about anticoagulation. And a couple of questions. One particularly was on the use of heparin compared to the newer oral anticoagulants. And then also, how long should anticoagulation continue after discharge for patient?
I mean, I think we have to be pragmatic in terms about whether we use the direct oral anticoagulants or the low molecular weight heparin. I think the major challenge with heparin is it's quite expensive in India. It is an injectable, so you have to treat patients at discharge, but also it's a biological product. It comes from porcine intestinal mucosa. So there is a supply issue which we will run into in the next few weeks, if not sooner. So I think direct oral anticoagulants we've used quite extensively when we have discharged patients with the VTE, and we've not seen any problems in terms of resolution or any excess bleeding. I think that is in terms of the use of the direct oral anticoagulants. The second issue is to do with how much should you do at the time of discharge. I think there has been an attempt to do studies on this, and I think we have not been particularly successful. But it's more related to the risk factors of the patient. I think, as the others have pointed out, if you're a diabetic, you've got cardiac and mobility is impaired, then those are your patients who are high risk of developing a VTE at home at discharge. So, and we have seen events where patients have been readmitted with pulmonary embolism. So I think it's being pragmatic about it and giving typically, we would say 4 to 6 weeks. You kind of invoke the duration that you use in joint replacement surgery. Extended is about 4 to 6 weeks. So that is the kind of time we would recommend.
Thank you very much, Pratima. And then the next question is for Sanjay, who, thank you also, Sanjay, for asking so many questions about all the different medications in the chat. So I'm afraid I can't go into all of those in detail now, but there's been a lot on steroids, whether we should be giving IV or oral. Some questions about the dose, which I think was answered, in fact, by Romani, but there have been a lot of people have been asking about that, and whether we should be giving methylprednisolone or dexamethasone. I know you have answered some things in the chat, but as they're recurrent, would you mind just summarising that for us, Sanjay? Thank you.
So thank you very much. And as it's been pointed out repeatedly throughout this seminar, the cornerstone of managing your hospitalized patient with an inflammatory response is corticosteroids. And low dose corticosteroids is probably the way forward. Remember, as we've got many eminent colleagues online today, that corticosteroids are not without their side effects. And so the lower the dose of corticosteroids we can get away with, the better. There are, and people have asked questions about high dose corticosteroids, and there was a question on the chat about a mg per kilogram of dexamethasone, which is an incredibly high dose of dexamethasone. I have to say there are studies that are about to kick off looking at higher dose corticosteroids versus lower dose corticosteroids, particularly in the context of preventing some of the pulmonary complications that we see after pulmonary inflammation in COVID-19. But I think we should wait for these studies before we advocate higher dose corticosteroids. Thank you.
Alison, may I just add quickly to that, which is that I completely agree with everything that Sanjay's just said. We have used at times high-dose methylprednisolone in patients with very, very severe ARDS in the Majuri protocol that some of you will be familiar with, or similar. There is no evidence base for this. And so this has been used pretty much as a rescue therapy in patients who look like they're otherwise not going to recover. And therefore, we haven't really got good evidence to support that. But outside of that context, I would agree with Sanjay that I'm not aware of any evidence that would support high-dose methylpred, and wait for studies.
Thank you very much. I hope that we've kind of covered the major things. Are any of my panelist colleagues, is there anything else they would particularly like to mention before we close the webinar? Okay, so with that, I'm about to hand over to Tara, but before I do, apparently one of the discussions on Twitter was about mucormycosis, which apparently Dr. Tandon is an expert in, and Wasim also knows a lot about, and apparently they've not seen a case of this, even though it's live on Twitter and WhatsApp groups. So with that, I'll hand back to Tara, and thank you very much for joining us, and thank you to all the panelists for all their time. Tara, I'll hand over to you.
Thanks, Alison. So I'd just like to thank all our speakers for a fantastic webinar this afternoon. I hope that it's been useful for people practicing across the world, as particularly over in India, and very happy to support everyone joining future webinars. So please look out for those on Twitter and through the other channels where you found all the details for this one. So once again, thank you very much to everyone, and good night.